you're on.
We're going to go ahead and get started, and appreciate you all being here. Is the Trauma in Pregnancy. It's a lecture series that the Society of Trauma Nurses put together. Now, I want to preface this, I am not an OB nurse to even, of all the places to work, OB would be my bottom. You guys scare me to death. I'm just telling you. I can handle or could handle even today, the traumas. We love that stuff. Get us a pregnant patient, Doris. That natural stuff makes us crazy. So anyway, but I have a huge respect for our women and infant staff and your knowledge and calm and coolness when those things, we kind of work under the same pressure. We kind of have that feast and famine and then that normal, and then way out of normal. So thank you for what you all do, and appreciate any time you come down, and certainly back when I was in the ED, come down and help in situations. And I have always said, the OB department or the women and infant is either the happiest place in the world or the saddest place in the world. And so we certainly had patients that were a traumatic patient, was in a trauma that was a pregnant woman, near delivery, and ends up in a motor vehicle crash, and baby nor mom survive, and just those, I just have vivid memories of doing CPR on this pregnant woman, and the OBGYN's at the bedside, and he's doing an emergency C-section while we're trying to, defibrillate her, and, it was like, Dr. Miller, get your hands out of that belly, we're going to defibrillate, and so it was just a horrible, I remember that day as a horrible day, and then I had 2 or 3 that way. But the OB staff was there, and they were ready, not only at the bedside to help us through that emergency C-section, because our expertise was the trauma piece. Your expertise was taking care of that mom and her pregnant situation that she was in, and then taking care of the baby, then, an ED nurse and an OB nurse standing at the other end ready to receive that baby. So anyway, I remember those days. It was, boy, and then Dr. Hof, there was another one that we had, same way. So anyway, kudos to the things that you do, and we appreciate that skill set that you all bring, and appreciate your willingness to help in those situations. So most unique about the pregnant trauma patient is that fact that we're caring for 2 individuals. Now, you guys out in the EMS, my goodness, you're even, we're in a nice, comfortable, area to take care of the patient. You're in the back of a truck or on the scene or whatever it is, and trying to get that patient to us. So, but you have 2 individuals, even though maybe that baby, the baby's still in utero, it's still 2 patients. And although that initial assessment and care that trauma patient will follow our advanced trauma life support guidelines and all the other things that we learn about, there are variations to both the assessment and treatment, and that is going to impact both the mother and the baby, that outcome. And so we need a knowledgeable trauma provider understands that care has to focus and expedite that resuscitative efforts for the mother. And that's going to give that fetus or that baby the best chance of survival. Best chance of survival is mother's survival. Trauma poses a serious and preventable risk to that pregnant woman and that fetus. Although the exact incidence remains pretty uncertain, trauma accounts for about 46% of all maternal deaths. And many of these deaths are avoidable with education about proper safety restraint use and the avoidance of intoxicating substances and distracted driving. I know when you may have questions from moms in your childbirth classes about, is it safe to wear a seatbelt? Am I going to hurt the baby if I put my brakes on and I have my seatbelt on? Is that going to hurt the baby? So there's a lot of education that we have to tell them. The best thing for you is to be restrained and keep within the passenger compartment of the car and not become ejected. So those kinds of teaching, and then certainly, we all become distracted in various ways, whether it's cell phone, music. We had a little gal who worked in the ED. She would eat fried chicken trying to drive. I was like, oh my goodness. I'm putting makeup on. What are those distracted things that people do? Certainly, we need to teach and say, please do not do those things. And it's estimated about 34% of pregnant patients involved in a motor vehicle crash were unrestrained. So again, that's where that education really has to get out there. And then one study said 45% of the trauma patients were found to be positive for intoxicants. So I don't know if you're seeing more and more women that have substance abuse as you're caring for them in their pregnant state, but we certainly see it in the emergency department. And then non-accidental trauma, such as domestic violence and suicide, are common in pregnancy. And these statistics likely are grossly underrated or underreported by the victims. Homicide rates of pregnant and postpartum women in New York City showed that homicide was the second most common cause of death among pregnant and postpartum women. And then suicide was responsible for about 10% of maternal deaths. And so we know we have a lot of women that suffer from postpartum depression and those kinds of things too. 13 to 19% of trauma in pregnancy is related to alcohol or drug use. Between 34 and 64 pregnant patients involved in motor vehicle crashes, again, are unrestrained. And then substance abuse is a factor in traumatic injuries of the trauma patient. And there was one study that showed that 45% of pregnant trauma patients were under the influence of an intoxicating substance. And then that intoxicant use lowers compliance with restraint use. So if you have alcohol on board or drug on board, you may not be with it to put your seatbelt on. So that all adds up. And then so education of drugs and alcohol and connection to trauma should be provided to women in childbearing years and during pregnancy. And so social service really should be offered to high-risk women in particular to provide additional support in pregnancy. And so over the last couple of years, we've done something called the Baby Safety Shower. This was a grant that Good Samaritan Hospital in Vincennes had been awarded, and part of that grant was they were going to reach out, and we were one of the hospitals they were reaching out to. So it was, Southern Indiana, we have a pretty high infant mortality, morbidity. So, how are we going to make changes? And so we looked at those women at risk, potential risk, whether it was low socioeconomic, maybe age, maybe development, maybe they had some learning issues, whatever it might be. And we reached out and invited in the safety shower. And so, they go through education, and it's only a couple of hours, but they go through several stations of, putting the car seat in, anything from how to give the baby a bath, signing them up for Medicaid. There's things on, from the Humane Society, when you have a dog in the home and now you bring baby, how that safety works. So there's a lot of safety involved in that. And so, but we also added last year from the folks here in Du Bois County, they have the models of the baby, one with the shaken infant, that they can see how the brain is affected by that shaking or movement. And then they have a drug and alcohol baby, and so they can see how those changes work. So anyway, this year, and this was always a joint venture with Trauma and Women and Infant, now our OB navigators are taking that on, and of course trauma's involved, but I'm stepping away and they're doing more of the legwork for this. But we'll be involved. The emergency department's there too during that safety shower, and they talk about when to bring your baby to the emergency department, when those things that should come, and talk about dosages of Tylenol and Motrin and when you give it, and the importance of giving them water. Just lots of things that we teach at that baby shower. So, but we realize that there's an issue with that socioeconomic and ability to understand some of those things that the patient needs to take care of their baby and themselves. So anyway, it's been a really great endeavor, and so far, of all the babies that we had in the 2 years, all of those, the first year all survived to 1, which is our goal. And then the second one, so far, all of those, April will be our 2-year for that group. So that was the goal, to keep those babies alive and make it to 1. And so it's a good thing. And we'll continue to do it as long as there's money to do that. They do get a car seat, and they get lots of other free things, and it's just like a baby shower. There's cake, there's punch, and we have a good time, but there's a lot of education that goes on. The top 3 causes of injury in pregnant women are motor vehicle crashes, falls, and then abuse, that intimate partner violence. You'll see that term anymore. And the CDC and the WHO, World Health Organization, they use that term, intimate partner violence, which is the same as domestic violence. And statistics vary among studies and geographic areas, but motor vehicle crashes remain the #1 cause of trauma in women with childbearing years. And intimate partner violence is suspected to be underreported, but they reported about 20%, and they expect that would be significantly higher. So providers, we need to educate on the proper use of restraints. Many women are misinformed that seatbelts, again, could affect the fetus. And further, many women in seatbelts, they just think it's uncomfortable. So it's many times is decrease in the maternal mortality from the motor vehicle crash is significant. Airbags detonate at 1,200 pounds of force, and the speed is about 230 miles per hour as it's coming out from that stationary place where it's at. And when they developed this, it was developed for male people that are 5'8" and weighing 180 pounds. That's the crash test, and it's going at 32 to 35 miles an hour in those crash tests. So it's made for that type of person. So a pregnant female, although she may weigh less than 180 pounds, she's certainly built very different than a 5'8" male that weighs 180 pounds. So they do provide protective effect for women, especially if they're over that 30-some miles per hour. So we don't want to discourage them, even though we know that crash tests are don't test for that. But they really should make an effort to have their sternum at least 10 inches from the steering wheel or dashboard. I have a little friend that's real short, and she just like, the steering wheel's like right here. And I'm always after her, you gotta get that back, because you're like in the steering wheel, you know. The pregnant women, of course, that belly's out there, and so they need to make sure that there's about 10 inches away from the sternum, from that steering wheel and dashboard. And there's no statistics that found distracted driving in pregnant population, but general population, age 18 to 29, 52% regularly text and email while driving, and this is a substantial portion of that childbearing age of women. So in 2009, about 5,500 people died in crashes, were distracted driver, and then about 500,000 were injured. And then crash dynamics were important in evaluating maternal and fetal injuries, and that's really going to help us assist us in anticipating injuries. And we know that proper use of seatbelts help to prevent ejections from the vehicle, prevents severe head injury, and then it lowers our mortality, again, for both the mother and the fetus. Mom survives, baby survives. So we've got to talk to them about proper positioning of that belt to protect that fetus and mother. And the National Highway Traffic Safety Administration advises the belt to be placed between the breast and mid-clavicular, and then positioned under the dome of the abdomen. So you can see that lap belt where that's at. And low on the hips and across the upper thighs. And this, wearing it too high on the abdomen certainly can cause fetal losses resulting from motor vehicle crashes. So they need to make sure it's down low, across the hips, and then across the chest. And it says that ethnic minorities may be less likely to use restraints, and so we really need to, you know, if you're doing Hispanic population education, make sure that they understand that seatbelt use. And that restraint will be a primary predictor of survival of the mother and the fetus. As we know, ejection from a vehicle and head trauma are likely to have a bad outcome. So the other thing is falls. There's a psychological and anatomical changes, physiological and anatomical changes of pregnancy. The pregnant woman is likely to be at higher risk for falls. Falls occur in the 2nd or the 6th, 7th, and 8th months of pregnancy. You can kind of follow along in your test. That's one of the test questions. Maybe number 9, I think, is the test question. But it occurs more in that 2nd and 3rd trimester. That center of gravity shifts forward to that growing fetus, and the increase in relaxin production and secretion causes joint hypermobility in the pregnant woman to prepare her body for delivery. but that loosening of those joints really puts her at risk for stability. And so the nerve roots of the lumbar and sacral spine become that sciatic nerve are stretched. And this results in some altered sensory to the pelvis and lower extremities. And then there's been a couple studies that have shown an increase in postural sway, which adds to that further instability. They kind of get that sway back. And so their posture is just kind of way off from what they're used to walking and moving. 20% of women reported falling at some time during their pregnancy. And I thought this was kind of interesting that women that were younger were more likely to fall as those over 35. I'm not sure how, I don't know how that correlates, but it was in the literature. And most falls occurred in the 6th through the 9th months that we said, and over 72% were found to have been caused by stairs or slippery floors. So safety, thinking about going downstairs and then making sure they're not walking on something slick. And so women that seek that medical care for falls, we really need to be thinking about domestic violence or that intimate partner violence, because there can be suspicious indicators. Bruises in various stages of healing, injuries to the breast, back, and thigh, a story that's inconsistent with the injury pattern, and then overly intrusive significant other. That person that just won't stay out of the conversation, won't let them answer, and then you're like, how did that door cause you to have that bruise? Or just trying to understand how that happens. So try to put the story with it and make sure that kind of jives for that patient. Intimate partner violence in pregnancy is thought to be greatly underreported. No other time in a woman's life is she more likely to be battered by an intimate partner. Domestic violence is about power and control. So be mindful of signs of the following. So we're looking at coercive behaviors, intimidation, emotional abuse, economic abuse, isolating the patient from friends and family. The patient may be present for falls or, may present for falls or other home-related injuries. So again, look at the breast, abdomen, back, genitalia for injuries at different stages of healing. Abused women are significantly younger and single, lower income, and a lower level of education compared to those not abused. Homicide resulting from intimate partner violence was the most common cause of maternal death in a statewide study in North Carolina, with non-whites being at much greater risk. And then teens are shown to be at 2.6 greater risk of being a victim of homicide during pregnancy as compared to adult women. So that answers that question number 6 that we're looking on intimate violence, partner violence. We're looking at, it says Mexican. It's not trying to point out that maybe the Hispanic or Mexican population is more, but any minority, we see women that are not white, of not white descent. Most common fetal injuries are abruption and early delivery and low birth rate. Pregnant women who are abused suffer greater complications during their pregnancy, and they tend to gain less weight and have higher incidence of anemia, infections, and bleeding. And also their rates of maternal depression, suicide, tobacco, alcohol, and drug use are higher. The first incidence of abuse may come during pregnancy, and then an existing abusive relationship will intensify, and the incidence of abuse may become more frequent than after that pregnancy. Nurses, we really need to encourage and then guide those women to create some kind of safety plan, because they're probably not going to let us contact the police unless it was an assault with a deadly weapon or intent for death. But we want to get them to understand, okay, so if you're not going to let us report, then get a good safety plan. Some kind of plan for them to get to safety. It can include safekeeping of important documents, having an extra set of keys, having telephone numbers, because a person might take their phone. If you're like me, I really don't know people's telephone numbers. When I was a kid in high school and you call your friends, you knew everybody's phone number. I couldn't tell you. I know my own number, but that may be the only one I know. So securing money, and then some kind of physical plan for escape. And the There is a website that they can go to, Center for Substance Abuse Treatment, Domestic Violence. It's out of Rockville, Maryland. There's lots of places that they can go, but we can get that information to them, and there is a hotline number they can call to help them if they are in a place where they need to get to safety. So when those patients present with trauma during pregnancies, we need to just maintain that high index of suspicion. And I'm sure many of you have been in this a long time, and you've had that patient and you're just like, this doesn't feel right, the hair on the back of your neck's a little raised, and nothing, it's just not, all the pieces are not coming together. So we just need to have that suspicion. And then recent study found that 3 screenings throughout pregnancy with a single direct question, and that question is, have you been hit, slapped, kicked, or otherwise physically hurt during this pregnancy? That was significantly, statistically important in increasing the reporting of prenatal violence, and that reporting went from 6% to almost 15% compared to the routine screening. So it's recommended that in that physical exam and that screening be done in the absence of the partner. We're pretty fortunate in the emergency department. We can take the patient to radiology and get them away, because no one goes with anyone to radiology, but I don't know when it'll be if you have an area where you can take the patient and keep them away from that intimate partner or have an excuse. Of course, back in the ambulance, that's another way. The partner doesn't ride ever in the back of the ambulance, so you can ask those questions. But ACOG recommends the following questions. 1, have you ever been emotionally or physically abused by your partner or someone important to you? Within the last year, have you been hit, slapped, kicked, or otherwise physically hurt by someone? And then if they say yes, you want to find out, well, how many times do you think that's been?
Lord of all life, you call us to respect the life you give us from the moment of our conception until our natural death. You give us a world teeming with life, and you trust us in its care. You call us to love each other as we love ourselves, calling us to love the lives of all people, showing no partiality. Lord of all life, give us the strength and the courage to answer your call. Glory be to the Father, and to the Son, and to the Holy Spirit, as it was in the beginning, is now, and will be forever. Amen.
So then, since you've been pregnant, have you been hit, slapped, kicked, or otherwise physically hurt by someone? If yes, then whom, and then how, and what those numbers. So they're saying if you get that screening tool and you do it out of the absence of that partner, ask those questions, they think they have a better indication of the patient actually intimate partner violence. So that's number 9 as we go through that test. And I don't know what they do in the offices now. It's been, my daughter's 35, so it's been a long time since I was at an OBGYN doctor to talk about being pregnant. So they may do that. I know we are asking more questions about violence and such. Okay, so the growth of that fetus increases the demands for oxygen delivery and tissue perfusion, and increasing in blood volume, about 40 to 50% occurs. But their red blood cells only increase by 30%. So there's kind of a dilutional anemia is what we'll call that. So their average hematocrit is about 35%. So that heart rate increases to 10 to 15 over the baseline. Their output increases 30 to 50%. And then it plateaus in that second trimester. And then there's a decrease of progesterone that's released, and the results are a gradual decrease in blood pressure in the first and second trimesters. And then it increases on that third trimester to pre-pregnancy level. And these help to cope with the blood loss of 500 to 1,000 cc's, which occurs during delivery. So it allows for increased volume, again, yet less red blood cells. So we know that during pregnancy the uterine arteries are dilated. And again, it's really trying to have adequate blood supply to maintain the placenta and the growth of that baby, and then the weight of the uterus and that growing fetus will cause compression onto that aorta, and so compromising blood flow to the fetus and the abdominal pelvic organs. And so when that happens, we really want to get that patient kind of tilted to the left to get that pressure of that baby off the top of that aorta. And then due to that increased blood volume, there can be little change in vitals with blood loss. They can have a significant blood loss, almost 2,000 cc's of blood that's lost, and them not showing any signs in their vital signs, any change in their vital signs. So that question we're looking at is number 7, cardiovascular changes with our normal pregnancies. We have increased heart rate, decreased vascular resistance, and an increase in blood volume. Then there's pulmonary changes. Our bodies are changing. That pregnant mom, her body is changing significantly during this time, and so the mucosa of the nasal passages and the oral pharynx, larynx, trachea become engorged, and those patients then can have shortness of breath, epistaxis, difficult intubation, and so that airway should be secure early in that pregnant patient. If it's been recommended that endotracheal tube, they actually talk about using 0.5 to 1 millimeter smaller than comparable non-pregnant women. So you may have to go a little bit smaller, and that will allow for an easier tube passage. It also decreases intubation trauma. So you may have found that in the past, in your practice. And then oxygen consumption increases about 20%, diminished O2 reserve, and buffering capacity. So this results in a rapid hypoxia and inability to compensate for acidosis that follows. And as that acidosis can cause life-threatening derangements and trauma, it's really vital that we recognize and treat that increased acidosis in the trauma patient. So total lung capacity is decreased. They can't get a good breath because this uterus is in the way, and it'll peak during that 3rd trimester of pregnancy. Everything kind of drops a little bit, and you get a little relief to be able to breathe a little easier. And then you have decrease in your functional residual capacity. So again, there's that at risk of hypoxia, and then we have a PaCO2 of 35 to 40 really needs to be considered abnormal. Trauma patient, pregnant patient, and it's kind of a late sign there. It's pretty amazing. I mean, there's a scripture that talks about us being amazingly made. Psalm 119 that talks about how our bodies are made. And when you just see all these changes that happens, it does show you just how remarkable we are made. There's neurological changes that happen in pregnancy. There's a vasodilation that can cause postural hypotension in the pregnant woman. I mean, how many times have they got up on the side of the bed too quickly and pass out? This can lead to feelings, again, of dizziness for them, and of course fainting. A change in that center of gravity alters their balance and their gait as they progress, and then that alteration adds to the risk of falls. We just talked about that earlier. And then the presentation of preeclampsia can mimic a traumatic brain injury. So this is really important to quickly distinguish between the two. We know preeclampsia is an abnormal condition in pregnancy, and it presents as an acute hypertension, proteinuria, and edema. And it's severe form eclampsia, and this disease progresses to the grand mal seizures, loss of consciousness, and it can be fatal. So imaging of the head should be used to rule out head injury in a mother, and the team can manage the prenatal complication of preeclampsia. Really needs to be assembled. So if it's been a significant injury, we're worried about a head injury, we wanted to distinguish that. So we'll talk a little bit about radiology and the trauma patient here. And then the increased release of progesterone decreases our gastric mobility. So the esophagus relaxes, and we have those gastric sphincters that relax, and that can lead to an increase in aspiration. So we really need to take good care to protect that airway and decompress that stomach. This one. And that uterus becomes an abdominal organ in the 2nd trimester. It displaces the bowel towards the upper and anterior portion of the abdomen, and this decreasing space in that abdominal cavity places an increased pressure on the hollow viscous organs and puts them under risk for rupture. So solid organs are at greater risk than fracture as well. So the stretching and increase in intra-abdominal pressure can result in desensitivity to the perinatal irritation, which occurs from free fluid or blood that's in that cavity. and the physical exam may show a lack of tenderness or rebound, tenderness or guarding. So we may not have the greatest abdominal exam just because of all that changing that's happening while that uterus is growing. And there's urological changes in pregnancy as well, and so there's an increase in pelvic blood flow to the pelvis. So those pelvic fractures are more likely to result in hemorrhage. So we have more blood flow there. You get a fracture, we know those bleed a lot, they can bleed even more because there's more blood there. And then due to the position of the uterus, the bladder is placed anteriorly and superiorly, and this position of the pelvis placed the bladder higher and is at risk for injury as well. And because of that higher GFR and decreasing room for the bladder in the pelvis, that bladder is likely to under more tension and more vulnerable to rupture. And so creatinine and blood urea nitrogen will increase in about half the normal pre-pregnancy rate. So additionally, there's just all these things that are going on. One of the big things that we can tell them is don't travel with a full bladder. Make sure that you empty your bladder before you get in the car, because that's going to give that baby a little more room and you're not going to have the likelihood of that bladder rupturing because of that. So triage, that trauma patient greater than 20 weeks should be preferentially transferred to a trauma center equipped to diagnose and manage those obstetric and neonatal emergencies, because we have those two patients, mom and baby. And so our EMS provides oxygen. You all are anticipating shock because this blood changes that have occurred during pregnancy. You want to get a hold of the ED early because we want to get the right team there. We want to call OB, we want to call that OB/GYN, get them at the bedside, and then transport that mother in that left lateral position to avoid that supine hypotension. So we're going to talk about assessment and management of that pregnant trauma patient. And I can remember those times when we do have those significantly injured pregnant moms. There is a ton of people. There's a ton of people in a trauma activation, but when you put double staff in there, it becomes just super busy in the trauma room. Trauma is a team sport. It takes a lot of us to make things go well. And with two trauma patients to take care of, again, there's even a greater need for teamwork. We have to work in coordination again with that obstetrician, the L&D nurses, radiologists, and maybe the neonatologist or NICU if you worked at a center that provided that. And then planning ahead in the event is necessary for rare times that will be needed. Anyway, we just have to be ready and have that team ready, hopefully before the patient gets there. And any trauma patient that's been identified as pregnant really should be transported to the closest recognized trauma center. And upon arrival to this trauma center, that mother's condition should be assessed and stabilized before we move to assessing the fetus. Again, the greatest chance for baby survival is mom survival. So primary maternal assessment, then we assess the fetus, and then secondary maternal assessment. Aggressive care for the mother gives, again, the baby the greatest chance of survival. All women of childbearing years should be tested for pregnancy. Optimize cardiac output by displacing the uterus to the left and giving that left lateral tilt or manual displacement, and that decreases that pressure on that inferior vena cava. The trauma surgeon, the obstetrician should be available at the initial assessment stage. All women, again, should be given, if they're in the childbearing years, let's find out if they're pregnant. Females between 10 and 60 have the potential to become pregnant. I mean, it's just really scary. 60. I'm 59. I can't get pregnant. But holy crap, 60 with a baby. Oh my goodness. I'm good being a grandma. So trauma centers, we're making an effort to avoid indwelling urinary catheters. We really have decreased that, but we may need to get a serum and let's say you could get a blood test to determine that pregnancy in a timely manner. And again, we don't want to do Foley's if we can avoid it at all. So that primary survey, that uterine compression of the vena cava presents an obstacle to resuscitation of the trauma patient. That weight of that fetus really reduced the venous return to the heart and decreased cardiac output, and so that worsens our shock. I can remember, I mean, there are certain things you remember. The first time you have morning sickness, you can remember, I mean, that's in my head forever. But that time that I laid flat on my back, I forget where I was, with some doctor's office, and I thought, I'm going to either throw up or pass out, because that baby was, laying right on top of that vena cava. It was, not getting enough blood supply. So you got to get them situated to get that displacing that uterus. So important thing, we want to maintain spinal precautions as indicated by the mechanism of injury, but ensure the patient's immobilized with a 15 to 30 degree tilt. And that's about 4 to 6 inches to the left. You can use a towel roll, a blanket under that long spine board, or a bolster to support that left side, and ensure that side rail is up on the left to maintain patient safety and reassure the patient that positioning. They may feel, unsettled because they're on the spine board and yet we're kind of tilting them, but just reassure them why we need to do that. This demonstrates incremental change or increase in cardiac output of the pregnant patient. It illustrates the benefit of displacement of the uterus through the use of the left lateral position. In that trauma patient, we want to maximize that cardiac output, and it really is vital to the well-being of the patient. So we can see that change in cardiac output as our gestation increases. Let me go back one. Number 10, I think that was a question on your test talking about that trauma patient. And so we want to maintain those spinal precautions and place that on that tilt 15 degrees or about 4 to 6 inches. Okay, you want to clear the airway per your standard ATLS or PHTLS. However, remember that the airway edema is more common in a pregnant trauma patient. And so, intubation could be difficult for these patients. And some authors recommended intubating, again, a size smaller or a half size smaller of the ET tube. Early NG placement may be required because of increased risk of aspiration due to more relaxed, again, that sphincters, the esophageal sphincter or the gastric sphincters. And then there's a delay in gastric emptying as well. And so chest tube placement really should be 1 to 2 inner spaces higher than usual because of the elevation of the diaphragm. So we're just thinking of our placement there. And then resuscitation with plaque cells is preferred over crystalloids in a hemodynamically unstable patient. Vasopressors should be avoided as they decrease blood flow to the uterus and placenta. If they're necessary to save the mother's life, Levophed and Epi compromise uterine perfusion, while ephedrine does not. So there's a decision made if you have to use pressors. But PAC cells, and we want to give them early. I am a very old nurse, and so I remember giving bags and bags and bags and bags of fluid, up to 8 bags of fluid, because the literature at the time said we give lots of crystalloid solutions. Well, we realized, we finally came to know that, crystalloid has no oxygen carrying capability. They need blood. So now, after that first liter or so, we're going to be considering giving blood to that patient. And if the resuscitation of the mother looks unlikely, then there's a decision to do a perimortem C-section. It has to be expedited. Initiate that within 4 minutes of the mother's rhythm changing for greatest chance of fetal survival. And then that physician's going to do a midline vertical incision, and that just gives them the greatest exposure. They can get in there faster, and it also minimizes the bleeding. And then the procedure from the skin to the fetus should take no longer than a minute to perform. And then neonatology should be at the bedside. Now, that being said, we're going to have a pediatrician there. We're going to have our OB nurses, women and infant folks up there to help us. But I remember how quickly they got those babies out. I was just amazed. And it was probably a minute, bam, baby out. So, trauma is the leading cause of maternal death, accounting up to about 46% of cases. Fetal death is more common occurrence than maternal death. So we may have mom survive, but baby still does not survive. So direct fetal injury is relatively uncommon because of the maternal soft tissues, that uterus, the placenta, amniotic fluid, all those things absorb and distribute energy to the below. that the baby would incur. And most common causes of fetal death is maternal shock, so which is associated with fetal mortality about 80%. And so we've got to keep mom, that's why it's so important to keep mom out of shock, because the baby, once mom goes into shock, we have an 80% loss of baby. So this explains why those efforts to assess fetal well-being are secondary to resuscitation of the mother. Our maternal physiological adaptations to blood loss. So there's like a mid, a moderate, and a severe. And we can see that, in mild, we'll have 20 to 25% of maternal blood volume. So that's about 1,200 to 1,500 ml of blood. They're tachycardic. They might be 100 and plus, 105. They'll have some peripheral constriction. We'll notice some cool or pale extremities. And then we have our moderate, where we're at 25 to 35% blood loss, about 2,000 ml. And then our tissue hypoxia occurs. So we're going to have tachycardia that's a little faster, about 120. And then they're probably not going to be urinating at that point, because blood flows, we're thinking about, the body's thinking about, I'm not going to give blood to these other areas. I'm trying to keep this person alive. And then severe, this is greater than 30%. So we've lost greater than 2,000 milliliters of blood. And so that getting to hemorrhagic shock, and our tissue hypoxia continues. We have tachycardia with a greater than 120 heart rate and hypotension. In these patients, we're going to see an altered level of consciousness. We're going to see no urine coming, disseminated intravascular coagulopathy, so DIC may be ensuing for these patients. And uterine arteries are typically vasodilated, but during the shock state, that vasoconstriction may result in a decreased uterine blood flow. So maintaining that arterial pressure is vitally important to both the mother and the baby, and we're going to save mom's life, but we're going to save baby's survival as well. And then signs of fetal compromise, the bradycardia, the tachycardia, that loss of beat-to-beat variability or recurrent decelerations. The mother's hemorrhage of the body will shut down, or shut blood from the placenta, and the fetal heart tone instability we'll notice maybe at the first sign impending maternal hemodynamic instability. So the evidence really links maternal acidosis to decreased fetal survival, and some fetal physiology may protect against hypoxia. In the third trimester, the fetus may shunt blood distribution to the heart, brain, and the adrenals. And additionally, the fetal hemoglobin has a greater affinity for oxygen than the adult hemoglobin. Therefore, fetal oxygen consumption really doesn't decrease until the oxygen delivery decreases about 50%. So, the baby's doing things to help too. So really, this kind of answers question 4, where it talks about the hemorrhagic shock in that pregnant patient can lead to fetal demise, fetal bradycardia, but then that pituitary insufficiency, it's due to the blood loss. It's not explained well in this lecture, but that's one of the answers they put on the test. But again, it's that relationship of blood loss. With a 40% increase in blood volume and 25% increase in red cell mass, the mother can lose significant blood without signs of hemodynamic instability, but the fetus may be in shock. So, children compensate really well and can hide how they're doing. They can hide how well they're doing by compensating for blood loss in a child. They lose 25-30%. Adults, in the non-pregnant state, and men, we start losing 20%, 25%. We're starting to show signs. We're showing the tachycardia. We're showing the blood loss from our blood pressure. And because of how our body changes during pregnancy, we can lose more blood and still not see that hemodynamic instability. But again, that baby could be in shock. Caution, just because the mother is stable does not mean the fetus is not at risk. So we want to really get that fetal monitoring on quickly. So We go to our secondary survey, so we're looking at our definitions of childbearing age may vary among centers, but typically the rule is 10 to 50. I feel a little bit better with 10 to 50 than 10 to 60. But obstetric history includes parity, which indicates any previous abortions, premature delivery, so we're trying to get that information. Now, if your pregnant mom was by herself and she's obtunded, we're not going to get that history, so we may not know that background for them. But we try to date that pregnancy. It helps us in directing management of care once that mom's been stabilized, if we can. Prior pregnancies and delivery histories really alert us to problems with current pregnancy, can raise concern regarding rare complications, did uterine rupture, or if they had a prior C-section. Now that'll probably be obvious when we see that C-section scar. That we may not know why she had to have that C-section. And then special attention will need to be given to women that have a known Rh positive, and we're going to talk a little bit about that here shortly. And then pregnant women involved in trauma should be tested for Rh status. There's a 5-digit system that's used to communicate the number of pregnancies and birth, your parity, and your number of times pregnant. So fetal assessment, fetal heart tones really should be assessed as soon as possible after their primary assessment. So that's number one of your questions, where it talks about this woman, and she's got pretty good vital signs. Her SATs are good. She's on some oxygen. So at that point, we've done our kind of primary assessment of the mom. Now we want to check on that fetus, and then we'll go to that other assessment. But fetal heart tones really should be assessed as soon as possible after we've done that primary assessment. They should be, our normals about 120 to 160, and they should be audible by Doppler 10 to 14 weeks. And we want to use a Doppler that's specific to that obstetric evaluation. It may not have significant enough range or for vascular studies for that adult population, so we want to get one that is for obstetrics. And the fetal heart rate may not be heard even though the fetus is viable, and the clinical picture may be confused. So fetal monitoring should be continuous for any fetus age greater than 23 weeks, even if no significant maternal injury is identified, and that monitoring can be continuously monitored, should be for 4 to 6 hours. We're looking for bradycardia, tachycardia, loss of beat-to-beat variability, or recurrent decelerations, examples of those non-reassuring patterns in fetal heart tones. And when the mother is actively hemorrhaging, her body will shed blood from the placenta to supply her own vital organs, her brain, her lungs, her heart. So the fetal heart tone instability may be your first sign of impending maternal hemorrhage or hemodynamic instability. And so that abdomen should be examined for gestational age, the presence of contractions or rigidity, any signs of bruising. Fetal viability typically occurs when the fundus is 3 to 4 centimeters above the umbilicus, and contractions of the uterus may indicate preterm labor. And then a rigid uterus or abdomen can indicate placental abruption. Some resources really recommend a sterile speculum exam to look for ruptured membranes or bleeding. A visual exam of the perineum should be done to look for frank bleeding or the presence of amniotic fluid. And if there's any concern for ruptured membranes, sterile gloves need to be used for the exam. And preterm labor is expected. The cervix should be examined for effacement or dilatation. The other thing, it said, monitor the mom, the baby, fetal heart tones. If they're involved in trauma, 4 to 6 hours, even if mom shows no signs of hemorrhage. But the other thing that fetal heart tones does is, what a great reassurance is that to that mom, to hear those heart tones. There's just that feeling of, oh my gosh, baby's still, heart's still beating. There's just a sigh of relief. And I know we have the ultrasound in the emergency department, and Dr. Lilly, that was one of the things he loved to do, was to take that in so mom could hear those fetal heart tones, because he felt like that was such a reassurance. Brought her blood pressure down, brought down her heart rate, because now she's not so anxious. So your fetal monitoring, that's like Greek. I don't have a clue what those show. I can see if there's where you have a contraction, but Anyway, the electronal fetal heart monitor is primarily used to detect those fetal hypoxia, so the lack of sufficient oxygenation. You would hope to catch it early enough to prevent neurological damage in that newborn baby. Indications of fetal hypoxia are represented by prolonged deviations from a normal baseline pattern in that fetal heart rate. And so the normal heart rate range 120 to 160 or so per minute, and it can be heard with the conventional stethoscope about 20 weeks. With the Doppler, it can be detected 12 to 14 weeks gestation. And the fetal heart rate is controlled by the autonomic nervous system. There's an inhibitory influence coming from the vagus nerve and excitatory influence coming from the sympathetic nervous system. So stimulation of those peripheral nerves of the fetus by its own activity, such as movement or uterine contraction, causes acceleration or an increase in that baby's heart rate. And then deceleration, or the drop of the fetal heart rate, usually indicates the fetus is in some kind of stress. Something's causing its stress. And so it may be a good healthy sign if it corresponds with movement of the uterine contractions, but it may be a bad sign if it's apart from something other than that. So again, we're assessing for fetal heart tones, baseline variability, looking for those decels and such. Where we're going to take this patient, well, there was always you probably don't know this, there was this unwritten rule of when there was a pregnant mom that came in that, Doris was going to get the elevator, Donna's going to get the bed, and we're going to run as fast as we can to get that patient upstairs because, and then someone's calling OB to say we're on our way with an imminent delivery. I'll tell a funny story. I don't know if people remember Dave Merkley. Maybe Marty will remember Dave. So we went out, and we had gotten a call that this was prior to cell phones. People had left their house and said, we're on our way. This was an Amish mom that had multiple births. I think this was number 7. And so she's in the back. She gets there. Dave and I run out. She's in the back. It's like, oh my gosh. And so Dave pulls down her underpants, and he sees the baby crowning. And then he pulls the underpants up, and I'm like, take the underpants off. Take the underpants off. That's how we keep that baby in there. It's not going to work. Okay. So anyway, we were running like crazy, getting mom upstairs, and I think she delivered within 2 minutes. I mean, it was just like, she primarily delivered in the hallway as we were running. But they would never let us write that in policy, but it was what we planned. So. Okay, in the code, you're going to do CPR, you're going to write, if the baby's born, you're getting an elevator, and so. We want to get them to the right place, and so put them where the resources best meet the patient's need for both mom and baby, and then the standard care must be maintained for both of them. And then who admits? I'll tell you, in this lecture, it talks about the trauma surgeon and the OB doctor working together. If we have a significantly injured patient that's a OB patient, we're not keeping them here. We're going to ship because, the baby may be premature, so they're going to need a NICU. So that may be where we're going to send the patient. But certainly for some trauma facilities, they would keep those significantly injured moms. So the trauma surgeon obstetrician would consult on the best place for the patient. Probably the ED physician is going to be involved in that as well. And if the mother's severely injured, the best place is in a trauma intensive care unit with an OB nurse in attendance. And I think we talked about that before. We move an OB nurse up to help with monitoring and such. And if the mother has minor injuries, then maybe the patient's safe to be on the OB floor with checks by the trauma nurse. And then this really varies by protocols in hospitals. And so we just want to think about that, if that would happen, what we want to do with the patient. Rh immune globulin contains antibodies to the Rh factor in blood, and those antibodies come from donors who have become sensitized to the Rh factor, and that gives these Rh antibodies to an Rh negative pregnant woman, prevents her immune system from producing its own Rh antibodies, which could attack the Rh positive fetus's red blood cells. When introduced into the Rh negative mother's bloodstream, those Rh immunoglobulin antibodies locate any Rh positive fetal red blood cell that are present. So it's looking for it, trying to find it. And so the antibodies attach to the Rh positive red blood cell, and it makes that present of that mother's immune system. And although that Rh immune globulin antibodies destroy fetal red blood cells, it's not enough to destroy or to harm that fetus. That Rh immune globulin is given by injection. It's an IM injection. It's given to Rh negative mothers who will be carrying an Rh positive fetus. And while it prevents Rh sensitivities, the Rh immune globulin cannot prevent damage to those positive Rh positive fetus to the mother. It's already sensitized to that factor. In the maternal trauma, the, how do you say that? Kleihauer-Betke? Okay. Test has traditionally been used to detect transplacental hemorrhage so that the Rh negative woman could receive the appropriate Rh immune prophylaxis. And so this testing accurately predicts the risk of preterm after the maternal trauma. So clinical assessment really does not. We may not have a clear understanding of that. So with a negative test, post-trauma electronic fetal monitoring duration may be limited safely. With a positive test, the significant risk of preterm labor mandates detailed monitoring. So it has important advantages to that maternal trauma victims, regardless really of their Rh status. So this is answer to number 5. So your KB test is used to test for presence of fetal cells in that maternal circulation. Caution is necessary to reduce radiation exposure. So it should never be done at the expense of the mother's welfare, that we hold off doing a test because we're concerned about exposure. But all injuries need to be identified during primary and secondary assessment with the use of X-ray when necessary. Multiple injured trauma patients receive a substantial dose of radiation. Radiation exposure is cumulative, over your lifetime. I hate to think back of, this has nothing to do with pregnancy, but when CT was done routinely for kidney stones, we'd have these patients that would come in, and they might come in 10 times, and you'd look in their chart, and they had 10 CTs that all showed they had a kidney stone. Well, if it looks like a duck and walks like a duck, it's probably a duck. So you don't have to go back to CT every time. So anyway, we want to know that we've got some people probably glow in the dark, that had kidney stones, I'll just say that. So there is a cumulative effect, but a low individual risk for cancer becomes a greater public health issue when it's multiplied by a large number of examinations over a lifetime of the patient. So CT scans are a valuable resource and are becoming more easily accessible. They should not be replaced with clinical examination and should be used only in the appropriate patients. Ultrasound is safe. It has a fairly poor sensitivity for diagnosing abruption. However, if there's a clot, visualized prediction of abruption is high. So we do something called a FAST exam. This is an ultrasound test that we do in the emergency department. The ED physicians do to look for blood in the free blood that's in the abdominal area. And so really, this becomes less accurate in that trauma patient because, especially if the baby is of an increased gestational age, as the uterus is just crowding that whole abdominal cavity, so it's hard for them to even see where that blood might be. So use of plain films typically outweigh the use of the risk of radiation exposure. In the mid to late pregnancy, there's no single study that carries enough radiation to harm a fetus, and the highest radiation dose occurs with CT and is only indicated studies should be ordered. CT is non-invasive. It provides additional information related to retroperitoneum, which may be very difficult to look in any other way, and the GU tract. So more specific uterine and fetal injuries could be determined. So MRI, they really haven't seen that as associated with adverse fetal effects, and other than a brain flow study, there's really no indication for nuclear imaging at that point. So you can use X-ray. Need to be judicious, not just do just kind of let's just do head to toe. We've got to think about, well, if there's an injury here, let's do this test and those kinds of things. So medications, certainly we want to note for those medications their safety in pregnancy. And so there's very few that are really known to be really safe for a patient. We really want to weigh the risk and benefits. Although tetanus is not contraindicated, so we certainly can update them on their tetanus. We don't want to hold analgesics if they have pain. We want to make sure that we give those, and then anesthesia drugs kind of fall into that category C. Now the great thing is we have 24/7 pharmacy, So it's awesome to have them to come and help us. It helps us in the ED and in the house. Doesn't really help you guys out in the field. So follow your protocols for what you give to a pregnant mom en route to the hospital. Placental injury is a threat to both patients. Early separation of the placenta deprives the fetus of oxygen. It leads to hypoxia, leads to death if the fetus is not delivered quickly. And so further, that uterus is unable to contract to constrict bleeding vessels in that uterine wall, so the fetus remains within the uterus. So that mother's at risk for significant blood loss. Additionally, the thromboplastin, which is released as a result of abruption, can cause worsening DIC. So there's lots of bad things that happen. We just got to get that baby delivered. So a uterine cavity can hold the entire blood volume of an adult. So you have significant amount of blood loss hidden in that belly. If abruption is occult, the first sign of fetal and maternal compromise may be the non-reassuring fetal heart tones. And so that's why early fetal monitoring is important. I think we see that in question 3, that hemorrhagic shock of the pregnant patient. I told you that's wrong. That's not right. 3, I'm sorry, 3, there we go. 3 is not 4. 3 is 3. So on blunt trauma, the severity of injury is a good predictor for placental abruption. Let me go back to this. This is not good. Sorry for people watching this video. So the abruption is occult, the first sign of fetal and maternal compromise, maybe non-reassuring fetal heart tones. Oh, not true. So the placenta is not able to contract. We talked about that. It can't expand with the uterus. So we're not going to have the contractions for that. The first sign of maternal hemorrhage may be non-reassuring heart tones. That's true. We know that's true. Increased vascularity puts the mother at greater risk for hemorrhage. That's true. And the severity of the injuries is a good predictor for placental abruption. It's not a good indicator, the severity of the injuries, because it depends on where the injuries are. So D is that correct answer. The placenta does not have an ability to contract and expand, and so it can't vasoconstrict to control bleeding like the uterus. And with deceleration and acceleration injuries, there's a sharing. So deceleration injuries, I'm driving 55 miles an hour in my car and I hit another car, I hit a tree or I hit something, that's a decelerating, where I went 55 miles an hour, now I'm at 0. So, or there's an acceleration, I'm walking along with my dog and someone comes up behind me and hits me with a car. I was going pretty slow and now I'm accelerated. So those injuries tend to have a shearing effect on the patient and the organs. So it occurs within the tissues of the placenta, and that shearing causes separation of the placenta from the uterine wall. In severe blunt trauma, abruption is very common. It occurs about 40% of cases, and of those cases, fetal death occurs in about 60% of the time. Of all fetal deaths from trauma, abruption is the cause of at least 50%. Although there's a greater likelihood of abruption with severe blunt trauma, the occurrence of abruption cannot be predicted with use of severity. I should have waited to come to this page. I forgot about that. In injury measures such as an ISS. So Donna is our trauma registrar, one of our trauma registrars, and it's an injury severity score. And so I won't go into this because it's kind of a complicated little system, but she looks at the different injuries and they are weighted in such a way to give the patient a certain number to predict survivability, kind of. The higher the ISS, the less likely the patient's going to survive. So, anyway, but in pregnancy, all that kind of goes out the window. Patients beyond 24 weeks, measuring those uterine contraction is the most sensitive predictor of abruption. So again, monitoring of that patient really needs to happen very quickly as soon as that mother's stable and they can get that on, although we know many people will be working at the bedside of that mother pretty quickly. Most cases of abruption will exhibit frequent contractions, and they'll normally occur within the initial 4 hours of the trauma. So we really want to monitor them 4 to 6 hours for fetal heart tones, and then their contractions, looking for the minimum pregnancies of those patients that are 23 weeks or greater. And if there's no uterine tenderness, bleeding, fetal distress, serious maternal injuries and fewer than one contraction every 10 minutes, the risk of abruption really is pretty small. However, the literature does show rare causes of abruption occurring up to 6 days post-trauma. So when we are discharging those women that have been involved in a trauma, we really need to educate on them to talk about watching for discharge, vaginal bleeding, abdominal pain, maybe their belly's a little more rigid, or frequent contractions. If those things start happening, they need to make sure they get a hold of their physician or come straight to the emergency department. 6 days, that's a long time. So I feel like you're out of the woods and yet you're still not. Uterine abruption, this may result from hemorrhage of the uterine avulsions, disruption of the uterine wall, placenta, fetus, or umbilical cord. 75% of the uterine ruptures involved the fundus. And signs and symptoms of uterine rupture, of course, they're going to have uterine tenderness, those non-reassuring fetal heart tones, rapid hypovolemic shock, peritoneal irritation, distension, rebound tenderness, guarding, rigidity, and then risk factors are having a prior C-section or other uterine surgeries, or maybe they have some kind of malformation, and then maybe multiple gestations, multiple births. Direct fetal injury. That's a 3D reconstruction of a 37-week fetus after a motor vehicle crash. The fetal head injury is the most common. It occurs in maternal pelvic fractures, and that especially happens when that baby's starting to engage and it's kind of down in that pathway. And so because of that increased vascularity, increased splenic and retroperitoneal injury can occur. And in blunt trauma, most frequent injuries are head, intra-abdominal bleeding, and pelvic fractures. There's a higher incidence of hepatic and splenic and uterine injuries. Gastrointestinal or less common. Direct fetal injury, so less than 1% is severe blunt trauma. Maternal tissue is very protective. The most common is head injury, more common again when it's engaged into the pelvic area. And then maternal and fetal deaths are highest when internal injuries were to the thorax, abdomen, and pelvis. Pelvic fractures, maternal mortalities, about 9% compared to fetal mortality of 35%. So the baby, if they have a pelvic fracture, is a higher mortality rate than the mother. And then fetal deaths are more common with maternal vascular injuries due to that high risk of disruption of blood flow to the uterus. And the outcomes really depend on the degree of injury, unlike in abdominal trauma. So fetal head and clavicular injuries are common in pelvic fractures. And due to the close association between the pelvic fractures and urethral and bladder injuries, care really needs to take to observe for blood at the urethral meatus before you insert a urine catheter, Foley catheter. And then the diagnosis of pelvic fracture, CT can be used sparingly. Plain CCs or plain films are many times sufficient that you don't have to go further to a CT. And care really needs to be used with angiography due to the high levels of radiation associated with the procedure. Embolizing vessels feeding the uterus will compromise the fetus, so they really discourage that from happening. And then it's, however, if you have to save the mother's life, there's no therapy needs to be withheld. You've got to take care of that mom, and then provide lead shielding for the fetus if necessary. Pelvic fractures are not complete contraindication to vaginal delivery, but severely dislocated fractures or large areas of healing bone may prevent it. So one study showed that 75% of women that have pelvic fractures in their third trimesters were actually able to give the birth vaginally. Penetrating abdominal trauma. Now that depends on the source and the type of injury. There's about a 40 to 70% fetal demise rate and about 5 to 10% maternal death rate. So pregnancy may be protected for the mother due to that displacement of those internal organs. It's protected. The mom is protected because that baby's now in front. Mom protects because of all the fluid that surrounds the baby and all those pieces. But now baby protects mom in a penetrating injury. If the upper abdomen is injured, there's more likely to be a bowel injury, or lower abdomen is more likely to injure the fetus. So the decision to take the patient to surgery should depend on the location of the injury, size of the uterus, the maternal and fetal vitals. Injuries in the upper abdomen are usually be handled with surgery. If both mother and baby are stable and the injuries in the lower abdomen, a conservative approach may be appropriate. Massive hemorrhage can occur from uterine injuries due to the blood that's shunted to the uterus. So a quick control of bleeding has to be achieved. And really, gunshot wound, you just exclusively have to go to the OR, and they have to do some exploratory surgery to see where the injuries are. And then antibiotics for any bowel involvement. Perimortem cesarean section. In the event that there's cardiac arrest in a very pregnant patient, there's a perimortem C-section that should be considered as a potential life-saving procedure for both the mother and the fetus. Despite the attempt to displace the uterus and increase compression, attempts to restore circulation may be unsuccessful. So both obstruction of the abdominal aorta and decreased compliance of the thoracic cavity really makes CPR very inadequate to the pregnant patient, and a cesarean delivery may be the best option to save both patients. The minimal gestational age for perimortem C-section, it's really a pretty controversial issue. Compression of the aorta can occur as early as 20 weeks. It's unclear whether truly impacted the perfusion until 24 weeks. And further viability of the fetus usually around 23 to 24. So what's about the youngest gestation that you delivered here? Probably had to sit out. Survive.
28 weeker, but I was at a 24 weeker, but the transport team was here,
Okay.
the NICU team.
They're from Evansville, whatever. Okay. So they're going to be thinking about what gestation this baby is. And then, although there are some facilities that care for a fetus as young as 22 weeks, this perimortem cesarean section could be done in 22 to 24 and above. Quick rule of thumb: if the fundus is greater than or equal to 4 finger breadths above the umbilicus, the fetus is likely 24 weeks old. So that kind of gives you a rough estimate. And then the patient should not be transported to the OR. You don't take time for that. You do an emergency C-section in the emergency department. Have a delivery kit available for immediate use, and then neonatal resuscitation supplies and equipment, suction, intubation, warmer, Brazil bag, all those things need to be in the resuscitation room. And so, we're thinking about a trauma team, the obstetric team, maybe neonatal team. So again, mom is in trauma 1 as soon as trauma 5, baby's born, delivered. The OB staff and the trauma nurse was both in the trauma 6 for handoff of that baby. So, case reports of perimortem C-sections show that neonatal neurological outcomes are better if it occurs within 4 minutes of the arrest. And further maternal return to circulation was found to improve when the uterus is emptied. EAST, which is a trauma group, recommends that the premortem C-section be performed within 4 minutes of maternal arrest as well. So they're all concluding the same thing, 4 minutes. Brain damage occurs in the non-pregnant patient 4 to 6 minutes of anoxia. A pregnant woman can become anoxic sooner due to that decreased functional residual capacity. And if the fundus is 4 finger breadths above the umbilicus, CPR is ineffective for resuscitation. So you got to empty that uterus to improve the chance for maternal survival, so that you can do CPR that is good. And then fetus survival diminishes in the time between maternal death and delivery. Chest compression should be continued throughout the broad spectrum, or throughout the spectrum, and then antibiotics given to decrease the risk of postpartum infection. Well, we can imagine family support. You have to have comfort to the mother and the family by allowing them to be together at any opportunity, allowing the patient to hear the fetal heartbeat, ultrasound images, lessening the anxiety. In addition, concerns of the baby, the patient, and family may be experiencing guilt about the injury. Maybe mom was driving and had a wreck, or maybe it was dad that was driving and had a wreck, and now he feels guilty because now mom is in a life-threatening injury, and maybe his baby as well. Recommendations for fetal monitoring after trauma vary. Again, 6 hours is what they suggest. Allow some research suggests for 4 hours is acceptable, but 6 hours certainly is probably the one that we're looking at now. Domestic violence is an epidemic in the population of patients, and it's often underreported. Investigation of effective screening methods in the pregnant population really should be a priority. And I will tell you, we did the we did the human trafficking education last year's nursing competencies. This year we're actually working on a policy, and one of those will be a screening tool to help you with that. It's a ways down the road. We're just barely scratching into that. Not finding facilities that have that policy much. We are going to do some further out research to see if we can find, Renee from Magnet is going to put kind of a questionnaire out on their little network to see if we get some. But Vincent's, who's very active in finding those human trafficked, they don't have a policy. They're in the same. They're probably right at the same stage we are. So anyway, domestic violence is certainly something we're going to probably even get further into within this year. And because airbags were designed to protect an average-sized male who's restrained, further research and development should be conducted to ensure that pregnant women and their fetus are protected and not harmed by airbags. There's additional education or research that's going on in that. Virchow triad in pregnancy. So this refers to 3 factors which play a role in thrombus formation. So we want a clot to form, right? So in pregnancy, stasis, we have pregnancy venous stasis occurs from compression of that iliac veins as a result of that right iliac artery overlying the left iliac vein. The uterus is there, that pregnant uterus. And so then we also have some hormones that mediate venous distension or dilatation and decreased activity. So there's some stasis there. That's one quarter of the triangle. There's hypercoagulopathy. So those changes in procoagulant factors and anticoagulant and fibrolytic activity from the release of estrogen that results in more thrombin generation and less clot dissolution activity. So we're going to have some hypercoagulopathy. Wanting to form a clot. And then in trauma, that's the other corner of our triangle. Trauma leading to endothelial injury is the final factor in Virchow's triad. So thus the traumatic injury is pregnancy, puts the pregnant patient in an even greater risk for venous thrombus and its sequela. So meaning development of DVT. So if we look at question 8, talks about normal pregnancy that has 2 of the 3 factors of Virchow's triad in the pregnant trauma patient. Endovascular trauma compromises the last of the 3 factors, making the deep vein thrombosis. So they are at risk for that. And then thrombotic diseases in pregnancy. Pulmonary embolism is the main cause of death in pregnant women in developed countries. An increased activity is observed during pregnancy. Moreover, the risk of venous thromboembolic disease can be elevated in cases of inherited thrombophilia or other diseases that cause that to occur. And then according to presented guidelines at the American College of Chest Physicians, there's risk stratification of venous disease during pregnancy, and it's a condition proper antithrombotic really need to be implemented just like we do in other trauma patients. So we want to decrease that clot formation for them. So we know through this lecture that there are some physiological changes that occur. That impacts our assessment and our management of that trauma patient. Initial evaluation and treatment really need to focus on the mother's hemodynamic stability. Again, mom survives, baby survives. Implement widespread domestic violence screening Injury severity is not a predictor of abruption. It can occur with mild injury, and then education regarding restraints, distracted driving, substance abuse is important. Questions? Well, let's make sure we got all of our test questions correct. So number one was a 22-year-old female that was involved in a motor vehicle crash. She's pregnant. Gestational age, she said she's 32 weeks. Her vital signs are heart rate of 89, blood pressure 127/54, respiratory rate's 22. She has an SpO2 of 100%, a non-rebreather at 15 liters. Glasgow coma is 15. And after the primary assessment is completed, the nurse expects immediately to assist with that fetal assessment. See, that's something I want to just real quick. So just the importance of trending of vital signs, trending of the patient's Glasgow coma, or at least their alertness. That maybe one of the big indicators you might see is mom is now becoming more obtunded or less interactive with you because maybe she has lost enough blood that she's now starting down that stroke or that shock path. So I always like to see what my EMS vital signs were and then what my first vital signs are in the ED, and then watch those to see if I had an increase, decrease in heart rate and blood pressure. What did my SATs do? And then what was my Glasgow coma? Are they not responding like they should, or how they did on scene? So, and then when you go to the floor, you all are looking back to see, okay, what's my changes? So vital signs and their assessment of their Glasgow coma are super important to help you treat that patient. Pregnant women are most at risk for falls during the 6th, 7th, and 8th months of pregnancy. Which of the following is not true about blunt trauma in the pregnant patient? The severity of the injuries is a good predictor for placental abruption. That is not true. Because it can be a minor injury and still have that potential. Hemorrhagic shock in the trauma patient may lead to all the above: pituitary insufficiency, fetal demise, and fetal bradycardia. The Plehauer-Becky test is used to determine the presence of fetal cells in maternal circulation. Which woman is more at risk for domestic violence? For current statistics, and we picked B, which is a 19-year-old Mexican woman, 8th grade education, second pregnancy, unmarried, and with a live-in boyfriend. So again, you know, a teenager, lower education level, lower socioeconomic puts them at risk for that. Cardiovascular changes associated with normal pregnancy. We have that increased heart rate, decreased systemic vascular resistance, and increased blood volume. Normal pregnancy has 2 of the 3 factors of Virchow's triad. In the pregnant trauma patient, endovascular trauma compromises the last of the 3 factors, making the patient at risk for deep vein thrombosis, DVT. 9, when you screen for domestic violence in the pregnant patient, the best method is to ask that direct question of having the partner step out, and then ask within the past year or since you've been pregnant, have you been hit, slapped, kicked, or otherwise physically hurt by someone? And then number 10, when resuscitating the pregnant patient, trauma patient, which steps should be completed first? And so one of the things we need to do is get that baby from laying on that aorta. So we're going to maintain our spinal precautions, place them on the left tilt with a 15-degree or 4 to 6 inches. Okay. Well, thank you for coming, and hopefully it was beneficial to your knowledge of the trauma patient.